Yeah, but by which organ? Kidneys. Both the kidneys at a period of time, specifically in a minute. Okay, the percentage of a substance that is getting cleared of our body, that means from the plasma, because kidney is clearing out the substance from the plasma, right? So from the plasma, the percentage of the substance that is getting cleared out by both the kidneys in 1 minute, that is known as clearance. There can be multiple type of clearance, like urea clearance, that must have been cleared in your urea class, right? Some bit of clearance, urea clearance you have heard. Okay, so over here we will be discussing with the creatinine clearance. Now why this clearance is important? Okay, because you heard the term GFR, right? Full form? Glomerular filtration rate. What is the use of GFR? Why do we calculate GFR? Get it? Why do we calculate GFR? To estimate or evaluate the functioning condition of the kidney, how good the kidney is functioning, right? The filtration capacity of the kidney that you are measuring by GFR. Now how would you measure how much the kidney is working? Because kidney is a visceral organ, right? You cannot see, you cannot take out the kidney and cannot check. So you have to check somehow how good the kidney is functioning. So for that reason we see the GFR, that is the glomerulus of the kidney. How good is it filtering out? That is the glomerular filtration rate. Okay, so for that we need certain substance that is not even being secreted by the body or by the kidney, and neither it is getting absorbed by the kidney. Let's say there is a substance which is X. X is going to kidney. This is your kidney. Okay, after going, kidney is absorbing let's say X by 10%. Okay, X by 10% substance kidney is absorbing. Rest of the you can say 9 out of 10 X is excreting out. So all the substance is not excreting out. Some bit is getting reabsorbed by the kidney. So now, right now, if you estimate the how much is getting excreted, you will get 10% is being less secreted. Okay, now you cannot estimate the actual functioning condition of the kidney. So for that reason we need certain substance like X आया पूरा का पूरा X ही निकल गया. कुछ भी neither it is getting absorbed by the kidney, neither it is getting secreted by the kidney. Okay, in case of urea, what is happening? Some bit of urea is getting absorbed by the kidney, which is less, but it is significant enough. But in case of creatinine, the absorption percentage is very, very negligible. That is why in practical field, whenever we are estimating the GFR, we use the creatinine clearance as compared to urea clearance. Now there is one more substance that is known as inulin. Okay, inulin. What is happening with inulin? Whenever you are putting the inulin, because it is not produced in our body, you have to give it from outside. Like हम लोग before the testing we give the patient injection of inulin, and after that we measure how much inulin is coming out. And inulin is one substance which comes as it is coming out. Creatinine में थोड़ा बहुत absorption होता है, that is negligible. But in case of inulin, nothing is reabsorbing. Nothing at all. That is why inulin becomes the gold standard for estimation of the GFR. Okay. Now this was just little bit of rough idea what is clearance and why we estimate the clearance, what is the function of GFR and all. Now this today's topic and the last topic, that was urea, both these things like blood urea and serum creatinine, both we are using to estimate the functioning condition of the kidney. Okay, so this, if somebody is asking, there was a question as well in your internal assessment in the practical, like what are the serum markers or the blood markers to evaluate the kidney functions. There was simple question. Okay, so in the question also there was given the urea is raised, the creatinine is raised. So if you can see from there, you can just say that these are the markers for evaluation of kidney. Now between urea and creatinine is much more specific for kidney. Okay, urea can be increased because of other reasons as well. Okay, and more importantly, urea is getting more reabsorbed in the kidney as compared to creatinine. That is why creatinine becomes much more specific, organ specific. Like you remember that example of which one is more specific for pancreatitis, amylase or lipase? Lipase was more specific because amylase can get increased because of some other conditions as well. Same concept in case of urea and creatinine. Creatinine is much more specific for the kidney per se. Okay, that's all. First of all, you have to understand what is creatinine. Okay, creatinine is an excretory product that we don't need in our body. And from where it is being produced? Okay, we have creatine in our body which is getting synthesized by the liver and the kidney. Okay, so here comes your creatine. Okay, it acts as a source of energy which is stored in the skeletal muscles. Now what happens, this creatine is getting converted into creatine phosphate. Creatine phosphate. Here it takes up 1 unit of ATP and produces ADP. Fine. Now these two are the stored form of creatine. These two are the stored form of creatine in the muscles, in the skeletal muscles. Now what happens in the skeletal muscle, when these two gets used up, they produce energy as well as they release H2O, means they are getting dehydrated. Dehydration means they are losing the H2O. When they lose the H2O, they form the creatinine. Now this creatinine becomes an excretory product and our body don't need it. Now this creatinine goes into the blood, keeps on circulating in the blood, ultimately goes to the kidney and kidney excretes it out. Whatever percentage of it is going to the kidney, kidney is excreting it out. Now how much percentage? The total amount of creatine and creatine phosphate, total 2% of it every day is getting converted into creatinine and that is getting excreted out from the body. Fine, understandable. Where it is getting synthesized? In the liver and the kidney. Then it is getting converted into creatine phosphate and these two are the stored form of creatine. Both of them losing the water and getting converted into creatinine. Once they form creatinine, now it's an excretory product which is not necessary for our body, mixing up with the blood, going to the kidney and kidney is filtering it out. Fine, understandable? Okay, see what they have written. Creatinine is produced in the muscles from creatine by non-enzymatic irreversible dehydration. Now this process is irreversible. Once it forms creatinine, it will not go back to creatine or creatine phosphate. So that is why it's a irreversible dehydration. After losing the water, it is forming the creatinine. Okay, now creatine is synthesized in the liver and kidney from the amino acids and passes into the circulation and is taken up by the skeletal muscle. Okay, about 2% of the total creatine is converted daily into creatinine. The amount of creatinine produced is related to the muscle mass. Now there is a thing what it depends on. The more muscle you have, the more amount of creatinine your body will produce. That is why we can see one thing, in case of males, the normal range of creatinine is little bit higher as compared to the females, because generally the male has more muscle mass as compared to females. Fine. Second thing is, those people who are working out in gyms or they are taking excess amount of protein powder. If anybody is taking protein powder, you can see that in the container you can say creatine monohydrate is present, right? So that is an extra supplementation that you are taking. Why? So that it can go to muscle and give the more energy to the muscle. That is why they are bulking up, muscle bulking. Okay, but if it crosses the normal range, then it can be harmful for your kidney. So prolonged protein intake, or else the protein that you are taking which is more than the ethical dose that you should take, if you are taking more than that, that can hamper your kidney. That is why they give caution whenever you are using this kind of protein powder. Be cautious how much of protein you are using, because this contains this kind of creatine monohydrate as well. Fine. Okay, now once this creatinine is produced, it is released into the blood and then excreted by the kidneys. As simple as that. Whatever I have said over here, that is only written over here. Now this is the basic idea of creatinine. From where it is formed, how it is getting converted into, and which organ where it is getting converted, and how it is getting excreted. Now let's go to the topic, how to estimate. There is some reaction, some principle of the test. Okay. Now creatinine reacts with the picric acid in the presence of an alkali to form a orange red color creatinine picrate. You can see that creatinine is reacting with the picric acid in the presence of an alkaline medium and forming the creatinine picrate. As simple as that. The intensity of the orange red color is the measure of the amount of creatinine present in the blood that we have been doing in our last 3-4 practicals. That is the depending upon the Beer-Lambert's law. Okay, the concentration of the chromogen, how much light it is absorbing, depending upon the absorbance, we are estimating the value of the substance that is present in the serum sample or the blood sample that we are using. Over here also the same thing, the amount of creatinine that is present, it is reacting with the picric acid and then forming creatinine picrate, which is giving you a color that is orange to red color chromogen, and we are just estimating the absorbance of the chromogen by using the Beer-Lambert's law with the colorimeter. Simple? Okay. Now over here you can see one line is written that protein in the blood do not interfere as they are precipitated by tungstic acid. What do you mean by that? In the reaction I did not show anything like that, and neither even I am mentioning that what is going on. what is happening is, in our blood there are many other substances that is present. For example, ketone bodies are there, proteins are there, glucose are there. These are always there in our blood. So whenever you are taking the sample from the patient and you are taking the plasma or the serum, over there all these things are mixed up and they are also going to react with the picric acid. Okay, they will also react with the picric acid and they will also give some chromogen, and those chromogens will also have the same absorption, and because of that your absorbance value will be higher. So instead of the actual creatinine value, you will get a higher value, that is falsely raised value. To avoid that, we have to precipitate all these extra things. For that reason, we have to mix the serum sample with the tungstic acid. Fine. Once we are mixing it up, that protein and other impurities are getting precipitated, and then we are taking the supernatant. How to prepare the supernatant? In the following slides, I will show you. Okay. This test's reaction is known as the Jaffe's reaction. That has already been taught to you in your organic and inorganic components of the urine, right? The same reaction. Whenever you are adding picric acid along with creatinine, it will give a orange red color chromogen, and that is the Jaffe's reaction. The same principle we are using along with the Beer-Lambert's law. That's all. Okay. Next, what are the reagents that we are using? One is serum supernatant that we will prepare. Picric acid reagent, those are given in the kit. Okay, in the kit there will be three things. One is a picric acid reagent, also labeled as L1, buffer reagent labeled as L2, and creatinine standard that is given in the kit. Okay, creatinine standard, what is the concentration of the creatinine standard? 2 mg per deciliter. Okay, distilled water is there and serum supernatant is there. Now, this serum supernatant is already been produced. Okay, you people do not have to prepare the serum supernatant, but you have to know how we are preparing and why is it important to know for your perspective of view. Nobody will tell you to prepare the serum supernatant and then do the test. We will prepare and we will provide you. Okay, now serum supernatant, how to produce? Let's say this picric acid reagent. Okay, we have to mix along with the picric acid reagent. We will take 2 ml of picric acid reagent plus 0.2 ml of serum that we are taking from the patient. First of all, we will take the blood, we will centrifuge it and take the serum. Okay, from the serum we will take 0.2 ml and 2 ml of picric acid reagent. This is a ratio. Okay, this is the ratio. Like, let's say if I am adding 10 ml of picric acid, I will add 1 ml of serum. Okay, so the ratio becomes same, 10:1. Fine. Now once I am adding this much, after that I will mix it and I will again centrifuge it at a rate of 2500 to 3000 RPM for 10 minutes. Once I am centrifuging it, all the proteins and others inorganic materials that is present that can react with the picric acid, this will precipitate. Okay, and you will get a clear supernatant. Okay, let's say from there you will get a 2.2 ml of mixture total. Excluding the supernatant, you are getting more or less something around 2 ml if you exclude the supernatant. So 2.2 ml of mixture you are getting. From here you will take 1.1 ml of the sample. Okay. Now if you see in this 1.1 ml, how much is the picric acid? Ratio, as per ratio, 1 ml of picric acid. And how much is the serum concentration? 0.1 ml. Okay. Now let's keep it up to here only. Why is it important? I'll let you know. Okay, let's go. Now over here we will make the same kind of test tubes. Please focus in the screen first. B, S and T, right? Blank, standard and test. Like your other test, this test is little different. Why? Because you can see in the blank and the standard I am taking picric acid L1 as 1 ml and 1 ml. But in case of test I am not taking any picric acid. Why? Because this 1 ml is already mixed up in the serum supernatant. Fine. And in blank I am adding 0.1 ml of distilled water. In standard I am adding 0.1 ml of the creatinine standard. But in case of test I am not adding any of that. Because why? The serum sample is also mixed with this much. Got that? Clear? That is why I just showed you why I am preparing the serum supernatant and how am I preparing. So because of this ratio I am just taking 1.1 ml of the serum supernatant, and that is enough, equivalent with this portion. Fine. After this much is done, you have to add the buffer reagent that is marked as L2 and equally 0.1 ml, 0.1 ml, 0.1 ml. That will provide you the alkaline medium for the reaction to take place. Once that mixture is done, you have to keep it in the room temperature. Till now we used to incubate. Now we will not incubate, we will just keep it in the room temperature. Okay? We'll keep it in the room temperature for 20 minutes. After 20 minutes, all the color reagents, whatever conversion was there, happened, and after that you have to measure the absorbance. First you will go and measure the absorbance at 520 nanometer of wavelength. Okay, you will see the absorbance of the blank. Whatever value you are getting in the blank, you make the calorimeter at 0. That is doing your reagent blank as 0. You are setting your reagent blank as 0. Then you will measure the absorbance of the standard, absorbance of the test, and then you have to put it in the equation of absorbance of the test upon absorbance of the standard into concentration of the creatinine, that is 2 mg per deciliter. Whatever value you are getting, that is your creatinine concentration. You have any doubt? Yeah.
So the picric acid reagent in the
Yeah.
like what you have explained, I will not follow this picric acid.
Okay, see, in case of blank I am taking 1 ml of picric acid reagent, in case of standard I am taking 1 ml of picric acid reagent, but over in test I am not taking any kind of picric acid reagent. Why? Because in the serum supernatant that I am preparing, over there I have already added picric acid reagent 2 ml and serum of 0.2 ml. Then I have centrifuged it. If I would have added 1 ml and 0.1 ml, after that if I would have centrifuged, some bit of centrifuged product would have been discarded. So I will never get 1.1 ml total. So that's why I have to make it in 2 ml plus 0.2 ml. So whatever after centrifugation, whatever value I am getting from there, I am just taking the clear supernatant of 1.1 ml. And over here the things are in 10:1 ratio. Right? From here 10:1 ratio. So that means 1 ml is our picric acid only and 1 ml is our serum only. So in case of other tests, what you used to do? We used to take the same reagent in all the test tubes and the serum in all the test tubes. In the serum in the test sample, standard in the standard, blank mein distilled water. Right? But over here we have to discard the unwanted particles. That's why we have to prepare the supernatant so that our serum is also equivalent as well as the unwanted particles are also getting cleared off from the preparation. Right? Got it? Okay. Now calculation is very easy, just you have to set the reagent blank as 0, then measure the absorbance of the test and absorbance of the standard, put it T upon S and multiply it with the concentration of the standard that is given to you. That's all. Okay, let's move to the next thing. Now what are the clinical correlation? Means what is the normal level of the creatinine that is there in our body. In case of healthy males, it should be 0.6 to 1.2 milligram per deciliter. Some books may vary, some labs may vary in the ranges. Whenever some lab is performing the test, as per the kit they are using, they will use that standard. The kit that we are using, as per that kit, this is 0.6 to 1.2. Some labs uses some other kit and this can vary up to 1.3, 1.4. Up to according to the lab and whatever kit they are performing, whatever kit they are using, according to that. Okay. Now, in case of healthy females, the normal creatinine level is 0.5 to 1.1 milligram per deciliter. Now, you can see here that in case of males, it is 0.6 to 1.2. In case of female, it is 0.5 to 1.1, which is little less as compared to the males. That is because of the muscle mass difference. Fine. Now, normal daily excretion of creatinine in urine is 1.1 to 2 gram per day, or else you can say it as 90 to 150 milligram per deciliter. Okay, that means what? The amount of creatinine that is present in your urine is 1 to 2 gram per day, or else 90 to 150 milligram per deciliter. Now, can anybody tell me how you can convert 1.2 gram per day to milligram per deciliter? Can you convert? The necessity of this milligram per deciliter is for the calculation of clearance. You cannot calculate clearance with this value. ग्राम per day से तुम clearance calculate नहीं कर सकते. क्यों नहीं कर सकते? I'll explain. Okay, but can you convert this 1.2 gram per day to 90 to 150 milligram per deciliter? No, it is 90 to 150. But how come this and this are equivalent? How to convert? Let's say I'm saying you there is a patient A who has urinary creatinine of 1.5 gram per day. Okay. Now for this you have to estimate in a day how much urine the patient is passing. Without that you cannot estimate. Now let's say I'm saying the patient is passing 1.5 liter of urine per day, which is normal, right? Normal urine output is how much? 1.5 to 2.5 liter. More than 2.5 is polyuria, less than 800 is oliguria, less than 100 or something 500 is complete anuria, right? Okay. Now let's say 1.5 liter, which is normal. 1.5 gram is also normal. So in this patient, how to estimate the urinary creatinine? You have to convert in mg per dl. Let's say 1.5 divided by 1.5. Now it is becoming gram per liter. Right? Now simple thing is we have to convert it into milligram per deciliter. So 1.5 gram equal to how much gram? How much milligram? 1.5 gram equal to how much milligram? 1500 milligram. And 1.5 liter equal to how much deciliter? 15 deciliter. Right? So it comes how much? 100 mg per deciliter, which is normal range. Right? So this is how you have to convert. The reason behind conversion is for the ease of calculation when you are calculating the clearance. When you are calculating the clearance, you cannot put this value. Why? We will discuss that as well. Okay? For now, anybody has any doubt in the conversion? How is it happening? No, right? Fine? Everybody fine? Those who are little weak in maths, please bear with it. You have to understand this much. Everybody is fine? Okay. Now, what are the causes of increased level of creatinine in our body? First and foremost is renal failure or renal disorder. It can be any kind of nephrotic disease, nephritic disease, glomerular nephritis, FSGS, whatsoever. In any sort of renal disease, the creatinine will increase. Okay. Now, muscular dystrophies. There are various types of muscular dystrophies as well. There is something called dystrophin, which is completely absent in our body. If it is absent, you can get Duchenne muscular dystrophy. If it is less than the normal, you can get Becker's muscular dystrophy. These are the topics from physiology. When you will study in physiology, you will get to know in detail about it. Okay. So this kind of muscular dystrophies in the early stage, they become increased level of the creatinine. Later on, in these dystrophies, when the muscle become flaccid and fibrosed, that means muscle mass is decreasing, and that time you can have decreased amount of creatinine. But in the initial stage, always increased amount of creatinine. Okay. In poliomyelitis, in layman term we say polio. Somebody is having polio. Okay. The disease itself is known as poliomyelitis. In that case also, in the early stage, you will get increased level of creatinine. Okay. And in case of fever, like where the catabolic rate is very high, in those conditions also you can get increased level of creatinine. Fine. And when you can get decreased level of creatinine? Whenever you are losing muscle mass, that is muscle wasting disorder. Whenever you are wasting the muscle, somebody who is not taking food for a prolonged period of time. First of all, your body will try to cope up with the energy. When it is not being able to cope up with the energy, the muscle starts breaking down, right, to provide the energy for your body. And in that process, your muscle wasting starts. And that is why muscle wasting at the later on stage, in the late stages, you will have decreased amount of creatinine. Fine. There are certain products which is also reacting with the picric acid and giving you the color chromogen. Okay. First of all, there is ketone bodies like acetone, acetoacetic acid. Whenever these are present, these will react with the picric acid and give you the chromogen. And the patient who is having diabetic ketoacidosis, obviously they will have increased amount of ketone bodies in their body, and they will give you a false result. Okay, that is one limitation. If a person is having diabetic ketoacidosis, if you take the patient's blood sample, you will get falsely raised amount of creatinine as the normal creatinine level. Fine. One limitation. Second limitation is there are some other byproducts that is present in the blood, that is like proteins are there, glucose is there, ascorbic acids are there, urea is there. These all can also react with the picric acid and can give you a color chromogen. So that is second limitation. And how it is hampering? Whenever you are taking a reaction to take place, 80% of the color chromogen that you are getting, if you are not preparing that serum supernatant, let's say you are not preparing the serum supernatant, you are taking as the sample and just started testing, you will get color chromogen, and 80% of it is only because of the creatinine. The rest of the 20% is because of the other byproducts, and that is also giving you a falsely high result. So that means the specificity of the test is very less. Means if the test is showing 1.4, you cannot say this 1.4 is only because of creatinine. Probably 1.2 is for creatinine and rest of the 0.2 is because of the other metabolic products. Got it? So that means the specificity of the test is reduced. For example, if I want to recall like Rothera's test, which is very specific, means if it is positive, means it is definitely because of ketone bodies only and nothing can react. Over here, other products can also react, so it is not being specific. Okay, that is what is the second limitation, that is less specificity. Third thing is the temperature and the pH. The temperature is the room temperature when you are doing the test. Okay, let's say your room temperature should be around 30-35 degrees centigrade, and your room temperature is in the lab. Let's say you have artificially created the room temperature and the temperature is 15 degrees centigrade. Obviously, there will be little bit of discrepancies of the result. You have to keep it in the room temperature. Fine. Second thing is pH. Let's say the same example of the diabetic ketoacidosis. What is happening in diabetic ketoacidosis? Patient is having diabetes, patient is having ketosis, and patient is having acidosis. Acidosis means when the pH of the blood is getting less than 7.35. Normal range is 7.35 to 7.45. If it is getting less than that, that is acidosis. So if the patient is having diabetic ketoacidosis, obviously the pH of the patient's blood is acidic, and in that condition your result will also get altered. Got it? So these are the three limitations. First is ketone bodies will react and give falsely high result. Second thing is your proteins, glucose, ascorbic acid and other byproducts can also react and give falsely high result, which decreases the specificity of the test. And third is pH and temperature can also alter the result of serum creatinine that you are getting. Fine. Now we are going to the creatinine clearance. This much portion what we have covered till now is your serum creatinine estimation. Up to that much is what you are going to do in the lab. Now this creatinine clearance is important from the theory perspective of view. Okay, that is why I'll just try to explain it. This will all be again covered to you in your theory classes again. Okay, now for this creatinine clearance there is one more thing that you have to estimate. That is, let's say I have said you about the definition of clearance, right? Clearance definition is clear. Okay, let's see. Clearance of a substance is the volume of plasma completely cleared of the substance per unit time by both the kidneys. Now this is definition. Words are little tricky, but ultimately if you see, clearance of a substance, let's say substance is X, is the volume of the plasma is completely cleared of X per unit time by both the kidneys. Means if there is a X substance is present in 100 ml, how much amount of X can be cleared off by both the kidneys in a 1 minute of time. Whatever you can clear off, that is the value of your clearance. That is why we calculate clearance as ml per minute. How much ml of the substance you can clear by both the kidneys in 1 minute. So that is why it is expressed as ml per minute. Okay. Now creatinine clearance is defined as the volume of plasma which is completely cleared of creatinine in 1 minute by both the kidneys. Got it? Now difficulties over here. Okay. Now it is calculated by the following formula, that the formula is U into V divided by P. Now what does that indicate? U means the concentration of the creatinine in the urine. That is why we require this value, this unit, that is mg per dl. For P means concentration of the creatinine in the plasma or the serum, and V means the volume of urine. Fine. Now let's say if the concentration in the plasma is how much? Normal is 0.6 to 1.2, right? Let's say I am taking it as 1. That is normal. 1 mg per dl. Okay. I have to now estimate the volume of urine and I have to estimate the urine concentration of the creatinine. Now if I take the urine concentration with this, can I calculate with mg per dl with gram per day? No. For that reason I have to convert it into mg per dl. Got it? Let's say I am taking this exact example only. This exact example. So over here I am getting 100 mg per deciliter. Right? So my U is done, P is done. Okay? When you will be doing the next part of creatinine clearance, that time you have to estimate this thing. Today we are not estimating this thing. That's why we are not doing this part. This is just for understanding. We are doing only the plasma part. Now once you are getting this U and P, now you have to estimate the volume of urine. How much urine you are passing. How to estimate it? Let's say he comes to me and tells me that, sir, I want to estimate my urine output. How much I am passing urine. So right now if I tell him, okay, pass some urine in the container. I don't know from which time he is holding his urine. Okay, he can be like he has passed urine few minutes back or else probably 3 hours back. So I don't know. As soon as the patient comes, I'll tell him, go void, clear off your urine and come. Fine. Now your bladder is completely empty. Let's say this is 3 p.m. right now. Your bladder is completely empty after voiding. From now onwards, I'll give you a container to pass urine in the same container for the 24 hours till next day. Over 24 hours, whatever urine output you are having, that is your 24-hour urine output. Right? For this person, how much was it? 1.5 liter. So I have to convert this 1.5 liter per day into ml per minute. I have to convert it into that because that is my unit of clearance. right? So how to convert? 1.5 liter means 1500 ml, and 1 day means 24 into 60 minute. So that becomes my ml per minute. Understood? So I will just put this exact value over here, that is 100 divided by 1 mg per dl cancelled into 1500 divided by 24 into 60 ml per minute. Any doubts till now? Fine. Somebody calculate, the values will come something around 104 ml per minute. Okay. So if you are getting this much value, what is the normal GFR? 125 ml per minute. It's a very simple question that was given in your internal assessment as well. What is GFR? The full form of GFR, and what is the normal value? That's all. This is your normal value. But this is the optimum, means 100% we catch hold. For a normal kidney, somebody's kidneys functioning can be up and down. Somebody's functioning properly fine, somebody's little bit less, but which is normal. So the range is between 90 to 125 ml per minute is normal. This is your normal range of GFR. Anything less than 90 is your kidney is defective. Okay, so this value what you are getting, this is your GFR by the clearance. Got it? Now over here you can see I am getting 104 of a patient whose creatinine concentration in the urine is 1.5 gram, which is also normal. Urine output is 1.5 liter per day, which is also normal, and his GFR also came 104. That means this person is completely fine and normal, healthy person. Okay, whatever values you want to change, you change the values and your result will also change. Okay, now how to evaluate a patient's condition? First of all, the normal values can vary from 95 to 140 ml per minute in case of males. In case of females, it can be 85 to 125 ml per minute. Okay, and creatinine clearance is decreased in case of impaired renal function. That means whenever the kidney is not functioning, your creatinine clearance will decrease. How? Let's say this is your glomerulus. This is your glomerulus, right? Okay, now something happened, this basement membrane got damaged. Whatever the disease is, because of this basement membrane got damaged of the glomerulus. Now creatinine is coming with the urine. It should get filtered out and it should pass. Because the basement membrane cannot filter it out, the creatinine will go back into the circulation again and it will keep on circulating in the blood. Creatinine ratio is keep on increasing and the clearance will keep on decreasing. Got it? In this patient, if you check the blood creatinine or the serum creatinine, that will be raised, but urea creatinine clearance will be decreased because it is not coming out in the urine. Got it? So that is what means if the creatinine clearance is decreased, it indicates impaired renal function. That means the kidney is not functioning properly. Now how to understand what is the grading, how bad the kidney is suffering? Okay, let's say the GFR is 125 is my gold standard. That means if somebody is having 125 means 100% nephrons are functioning. Nothing is damaged, everything is completely fine. Now this person got 104. So how much percentage this person is having? That is 104 divided by 125 into 100%. Right? So how much it comes? Around 80 to 83%. Okay. Any percentage which is more than 70, that means the kidney's functions are normal. Okay. If it is less than 70 but more than 50, that means mild renal damage. Less than 50%, more than 20%, between 20 to 49%, it's a moderate renal damage. Anything less than 20% means severe renal damage. Fine. Less than 20% means this will be around less than 25 ml per minute. Okay. If your GFR is getting less than 25 ml per minute, that means your kidneys are severely damaged. Fine. Any doubts? Okay. Now one thing is written over here that the creatinine clearance is a good indicator of GFR. Why is it a good indicator of GFR? In the beginning I have said because it is not getting absorbed, not getting excreted by the kidney. It is neither getting reabsorbed, neither getting secreted by the kidney. the percentage which is getting reabsorbed is very negligible. That is why in clinical practices we are using creatinine. Inulin you have to give from outside, and that is costly as well, and you have to take it out again. That is why it is used for a lab purposes, lab experiments purposes only we are using inulin. And if somebody is asking you what is the gold standard per substance to estimate the GFR, that's your answer should be inulin. That's a gold standard. But practically what we are using? Creatinine. Why not urea? Because urea can get reabsorbed. It can get altered by our diet as well, but creatinine don't get altered by our diet. Okay, it is completely proportional to your muscle mass. So that is why creatinine is much better for estimating GFR or the clearance as compared to the urea. Fine? Okay. Keep it in your hand only. Was that 1000 microliter proper? Let's see. You react. Yeah, it's fine. Though little less than this. Sure.
Sir, you can change for the distance. Change for the
No. You took only this.
Fine.
Fine. Now, how much is distilled water you need? How much distilled water you need?
0.1.
Then, will you take it with this one?
Sir, it doesn't need.
You have to curve it. Otherwise, how will it come? To curve it and take it. And discard. Discard that.